Achoo! Okay, welcome to Unit 14, Allergy and Overview. That was my attempt at being funny. Haha. Today we're going to be talking about allergies. When you look at allergies, it's probably one of the most common things you're going to see out in the field with the people. It's thought that there's over 50 million people in the United States alone that have some form of allergy, whether that be an allergy to a food, an item in the environment, a plant. There's many different things that people can be allergic to. It's kind of interesting when you look through the different possibilities. You know, there are molds and mites and certain medications, animal dander, even dyes, perfumes, tobacco smoke can all be things that can cause allergies. So a lot of different possibilities out there. It is said to be the #1 cause of missed work and school. And the most common allergy, or the most common allergy I think that you'll run into, is hay fever, which is considered the most common chronic illness in the United States. And that's mostly because it's really hard to get rid of. Once you have allergies, unless you want to go through allergy shots, you really don't get rid of allergies. You just either avoid the allergen or you treat the symptoms once you get it. It's not something that you necessarily cure very often. And with that in mind, there's over $500 million spent per year on allergy treatments, both over the counter and prescription. So big business, allergies. What is allergies, or allergic rhinitis? So there's a lot of different allergies out there. This chapter likes to focus on allergic rhinitis or hay fever. There are different types, and when we talk about drug allergies and that sort of thing, a lot of these symptoms or how the allergy responds will be similar, but we're going to focus on allergic rhinitis just because it is so common. And it's a good way to kind of just talk about allergies and how we look at them, how we diagnose them, and then how we can treat them. So allergies are caused by IgE, and IgE is immunoglobulin gamma E. That is a mouthful. So that's why we call it IgE. It's a blood molecule. It's Y-shaped. And in people who have allergies, they have an abnormal shaped IgE. It's a reagenic antibody is what the book says. And reagenic just means that it is can cause allergic reactions, essentially. When you have allergic rhinitis, the symptoms can compose of the stuff we think of typically: sneezing, watery nose, stuffy nose, watery eyes, and then drippy nose. In children, it actually can include behavior issues, colic in small babies, restlessness, irritability. The book mentions a syndrome called allergic irritability syndrome. I have not heard of that yet. If anyone wants to do a little more research and post something on the forum, I'd be interested to find out more. Some of the most common allergens that we run into are tree pollen, grass, and weeds. And if anybody has been through that before, you know what that is. All right, allergy triggers. I think the most obvious is allergens. But interestingly enough, you can be more susceptible to allergies if you are tired, stressed out, have overexerted yourself, or we've gone through some crazy weather changes. I don't know if you've ever noticed, but people tend to get more miserable when the weather changes, when it gets real cold or when it starts to get warm. And when you're stressed or you're fatigued, I think your immune system's a little bit down. And so that allergy response has a easier way to find its way to the surface. And when we're looking at seasonal allergies, we were talking about the chronic rhinitis, there's usually different triggers, different times of the year. In the early spring, it's generally trees, and that's because they're releasing their pollen to try and reproduce. And in the late spring and summer, it's the grasses. Things are wet, things are growing. we have a chance to mow the lawn. We're dispersing that pollen. And in the fall, it's generally more weeds. And that's when we think of like hay fever. The book takes a second to mention insect stings in its own little section. And I think the reason they do that is there's just no other great way to place to put it in the book. And when you look at allergies, insect stings can have a very serious consequence very quickly. When you are looking at people with allergies, an allergy to weeds or grass causes, a drippy nose and watery eyes. But an insect sting for some people can actually cause death. And so they bring this up as a separate section. And the symptoms include rash, hive, difficulty breathing, throat closing, essentially anaphylactic shock. So for people with a known possibility of an allergic reaction to insect stings, one, they should always carry an EpiPen with them, just to be on the safe side. But they do offer some safety tips in the book. One is to move slowly. Don't swat or slap at the insects that can provoke them. And of course, I think these safety tips are probably good for all of us. I don't want to get stung either. When you are out and about, wear close-fitting clothes so that the insects cannot get inside. Use extreme caution after a rainstorm. I thought that was kind of interesting. So after it rains, I guess we've washed all the pollen away, and so there isn't as much food around for the bees, so they get more aggressive, which I thought was kind of interesting. Avoid smelling like a flower, looking like a flower, that sort of thing. And then if you do get stung, don't squeeze the stinger out. That will just put the venom in deeper into the body. You scrape it out using your finger or some other instrument that can scrape it. You don't want to squeeze the stinger because it does have venom in it. So just some safety tips on insect stings. All right, so people think they have an allergy. How do we figure out what type of allergy do they have? What are they allergic to? Well, we have what's called a scratch test. And what we do is we have the patient come in to the office and we will pick a certain number of allergens that we think the patient might be allergic to. You clean the patient's, and a lot of times they'll do it on the forearm, just like this picture right here. So you clean the area, and then you'll go ahead and mark it up to show what you're going to put in which location. And then they use this cool little, the lancet. It's actually 8 little lancets that you basically just press it into the skin and it creates the little scratches for you. And then you can drop the allergens onto each spot. And then the patient waits about 20 minutes, and then you come back and you measure. And I actually have had this done, and it's not the most pleasant thing with the scratches, but I will tell you what, once you get a reaction, that is like a big, red, itchy, uncomfortable response. And to sit and wait for 20 minutes for someone to read it, and then, of course, once it's done, you still really can't do much about it. So just keep in mind, if you're doing diagnostic allergy tests for a patient, be sympathetic because it certainly does not feel good. One side note with allergy tests and something to keep in mind, in order to have a valid test, we can't have any medications in the system that would alter the results. So patients need to discontinue any allergy medication at least 1 week prior to the allergy test. And that's something that's important to let people know when they're scheduling their appointments. And then, of course, if they're on any sort of steroid, they will need to discontinue that 30 days prior to any sort of testing. And the steroids actually bring the immune system down, so they could actually reduce the response and give you skewed results. So we want to make sure we discontinue those medications in advance. We also have the patch test. This one I haven't seen quite as often, and I would imagine because it has to be really uncomfortable. They soak gauze with the allergen, put it on your skin, tape it on your skin, and they check it at 24 and 48-hour intervals. And then they look at the size of the reaction to determine how allergic you are. And just imagine that whole time, if you are having a reaction, it's going to be itching. So I don't think the patch test is quite as common as the scratch test. I've definitely seen the scratch test more often. The third test is called an intradermal test, and this one, it's similar to the scratch test, except the allergen is actually injected below the skin, not dropped onto the surface of the skin. I see these used more often when we want to look at the level of a sensitivity that a patient has. If you do a just straight up intradermal test, yes, you will get a response in a wheel and say, yes, the patient's allergic. But sometimes there's a question of how allergic is the patient to this particular allergen. And what they'll do is they will take an allergen and dilute it down so it's less and less concentrated. And then they'll administer these different dilutions and look at how strong the response is. And essentially, when the response stops at a certain dilution, they can determine the sensitivity of the patient. And sometimes this can be important when we're looking at potentially life-threatening type of allergens, or if there are multiple allergens to be treated and they want to treat the most serious one, they can look at that as well. So the intradermal test, I would say, it's used, but it's used more to determine a level of sensitivity, not whether or not you're actually allergic. The scratch test is more often for that. The book mentions a couple laboratory tests. Again, I think these are used more to determine levels of sensitivity or types of sensitivity. It's not something that you'd use right away when you're trying to diagnose allergies. It's something you'd use in a more specialized situation. Nasal smears, that would be something if you're trying to determine if the person's symptoms are related to allergies, or is it possible that it's a bacterial source. So they'll take a smear of the nasal passage and then look and see, can they see items that are associated with a bacterial infection, which can include neutrophils. And then and when you're looking at possibly it being an allergic reaction, you might see more mast cells or eosinophils. So they look at what you find to determine what type of infection might be going on. And then there are some people who do have what they call chronic sinusitis, and sometimes sinus x-rays can help in determining the severity, extent, or whether or not it is actually chronic sinusitis. Again, you don't see those very often. It's more the skin test that you see more often. So you have allergies. How do we treat them? Well, the most common sense thing, and I think the thing you probably will tell most people, is to try to avoid those allergens. Of course, there are situations where we cannot do that. If you are allergic to grass and need to go outside, at some point you will probably be exposed to them. Or if you're like me and you have a cat and are allergic to cats, it's really hard to avoid them. So there are situations where we cannot avoid those allergens, so we look at what type of therapy is out there. And drug therapy is probably the most common thing that you're going to see. And we're going to go through some different classifications of drug therapy. This is where people start to get nervous because I start mentioning names of medications. When I mention names of medications, it's because they are common and ones that I think you should be familiar with just off the cuff. The reason for that is there are some medications that are just so common out in the field that they should just be kind of automatic. So we're actually going to cover allergy treatment again when we go into treatment of the respiratory tract. But I want to touch on them now because they are so common and we use them so much. So I'm going to walk through each one and you'll see, I'll give you an example right here. So we've got antihistamines. We'll talk about how they work and then I'll give you a couple examples. I think it's important to know the different classifications of drug therapy and to know an example or two of each. You'll kind of see based on the homework what I'm looking for. But like I said, I think these are important to know. I generally try to put the generic name down and not the brand names so that you can get to know them. But you'll notice that I will mention brand names when we go through lecture, just because sometimes it's easier to look things up that way and then get to the generic names. So antihistamines, most popular. You can buy them over the counter. They're the newer generation are once a day dosing. They don't cause drowsiness. They generally don't have side effects. So a lot of times people, when they're looking to treat allergies, will use antihistamines. And a histamine is a chemical that's produced in the allergy cascade in the body and can produce the runny nose, itchy, watery eyes. So when you use an antihistamine, that stops the histamines from working. Examples of that, the first one is loratadine, and that is the generic name for Claritin. that is a second generation antihistamine. Second generation just means it's been brought about more recently. They provide a lot less, they are dosed less often and have fewer side effects than first generation antihistamines, which is diphenhydramine. Diphenhydramine is also known as Benadryl. That's a first generation antihistamine. That has to be dosed every 4 to 6 hours and actually can cause quite a bit of drowsiness, dry eye, dry mouth for patients. And so Benadryl, I will always say, is a little bit stronger as an antihistamine, but the side effects limits its use. So for most people, I'll recommend something like loratadine to start. However, if someone's absolutely miserable and needs to get some sleep, no harm in taking a little Benadryl. It's going to make you sleepy, and it's also really going to dry out your nose and take care of your congestion. You'll also see people using decongestants. Pseudoephedrine, or Sudafed, that's the item that has been now put behind the counter, and you have to use your ID to purchase. And that is because people use pseudoephedrine to make methamphetamine these days. That is really unfortunate because pseudoephedrine is a really good decongestant. It helps to basically just dry out the nasal passages and really kind of open up the sinus area, make it easier to breathe. So pseudoephedrine, Sudafed is common, though we now have different laws. And if you head down to Oregon, you actually have to have a prescription to get pseudoephedrine. It's considered a controlled substance. So the controls around them can make it difficult sometimes. There is a lesser known or no, I shouldn't say lesser known, a lesser effective one that you can purchase over the counter called phenylephrine, and that's known as Sudafed PE. But if anyone asks what kind of decongestant they should use, I always say just get the good stuff. Get the pseudoephedrine, get your ID out, and head to the pharmacy. Another over-the-counter option, and this has been in the last couple of years, is steroids, specifically nasal steroids. You've heard, hopefully, of Flonase. That is called fluticasone. Fluticasone is the generic name. And there's beclomethasone. These are nasal sprays that have a steroid component to them. And the steroids actually fight many of the chemical components of the allergy cascade. So there's more than one chemical that gets produced when you are having allergies. Histamines is one. There's also something called a prostaglandin, and there's also something called a leukotriene. All those chemicals can be blocked by the steroids, which sometimes provides more effective relief from nasal congestion and a drippy nose. The nice thing about the steroids is they generally don't raise blood pressure like the decongestant can. It gives you local action because you spray the nasal spray up the nose, so you're actually concentrating the medication in the area. Where you take pseudoephedrine, that's going to go throughout the whole system, and there can be issues with increased heart rate, increased blood pressure. The fluticasone too, once you or both, all the nasal sprays, once you start using the steroid nasal sprays on a regular basis, you generally have 24/7 coverage, which is really nice. Once you start dosing it, you generally don't get symptoms back and have to redose. As long as you're using it consistently, the symptoms will stay away, and it's usually dosed once every 24 hours. We have something called cromolyn, and I use the name Nasocrom because the generic name is cromolyn. This is a medication that attacks another road to having allergies. It works against the release of histamine and leukotrienes. So those are, again, two chemicals I've already mentioned that can cause allergy response. This blocks their release, the cromolyn. We have anti-leukotrienes, or leukotriene receptor antagonists. I abbreviated that because it was really long on the slides. So it's in your book, written out. Examples of that are going to be montelukast and zerifilukast. You'll notice that both end in cast, K-A-S-T. That is something we commonly find in generic names in medicine, that we will have a certain ending that goes with classifications of medications, which sometimes can be a nice little hint for you when you're trying to remember a name of a med or classify a med. Sometimes if you remember things like cast means leukotriene, then if you ever see those last four letters in the name of a med, you can have a good idea of what it might be. But the anti-leukotrienes basically are that they stop the leukotrienes, again, a chemical that's released if you have allergy response. it will stop those leukotrienes, or it will sit on the receptor that a leukotriene will try to activate and keep it from activating that receptor, which then can cause allergy symptoms. The term antagonist versus agonist sometimes can be a little confusing. Basically, when you're thinking antagonist, you stop the receptor from doing what it wants to do. And in this case, this receptor wants to make an allergy response. So we are stopping that receptor from making that allergy response. And that would be to create chemicals that leukotrienes create. Another class of medications that you won't necessarily see out over the counter or even out in the field all that often, because they're kind of way down the line as far as treatment goes. These are for people with pretty severe problems. Epinephrine, of course, is what we use in EpiPens. So those are for people with life-threatening allergies. They would carry around epinephrine in the pen and use an injection if they were into a situation where they were having trouble breathing. And that's what it does is it opens up the bronchial passages so you can continue breathing until you can get treatment. Theophylline is in the same class where it helps to open up the airways. Again, it's not that commonly used out there. You have to have pretty nasty allergies in order to have a bronchodilator prescribed to you. Another one is monoclonal antibodies. It's called omalizumab, also known as Xolair. Again, this is where we're looking at going down to the antibody level. And this actually works on IgE itself and keeps IgE from working. And this is only used in situations where people have moderate to severe allergies, and they have to be asthma type allergies. So it's for someone with pretty severe asthma that has an allergy component to it. Their asthma is triggered from allergies. And so this is for someone who has a pretty strong problem. But just so you know, that type of medication is out there, though. I would say the three you're going to see most often are the first three that I listed. Those are the ones that you're really going to want to pay attention to. Now, we were talking about treatment and in the fact that we don't really cure allergies. All of these drug therapies are treating symptoms. They are preventing symptoms from spreading, but they don't actually treat the allergy problem itself. And that's where we look at something called immunotherapy or allergy shots. And you may have heard of this before. And essentially what it is it's a series of shots of basically allergenic extracts, so the allergens. You start out with real small amounts and you slowly work up to larger and larger amounts to help people create a tolerance to these allergies. It can be a very long-term process. I mean, we're talking years sometimes. And it's something where you actually have to go into the office to get these shots. So you have to have a pretty strong commitment if this is something that you want to do. Now, if you are a medical assistant and working with someone who is an ENT or someone who works with people with allergies, you may be in a situation where you do administer allergy shots. In that case, there are a few things that the book highlights as far as what you'll need to know to administer them. Allergy shots are always going to be under the skin. They're going to be sub-Q. It's never going to be into the muscle. It's always just going to be right under the skin. And you always want to make sure you're rotating the sites. You don't want to administer the shot in the same spot twice. And the reason for that is we're trying to give the patient a very controlled amount of that allergen so they can develop that immunity. And if you give one shot in the same place 1 week and then again in the next week, there may still be some of that allergen there, and then you're just kind of taking your titration off. All the extracts must be kept refrigerated, so if you ever find a situation where you have accidentally left it out or someone else has, they'll need to be discarded and get new ones because they aren't good anymore. Talked about rotating sites. In this situation, because these people generally are highly allergenic, we're talking possibly life-threatening, and we're giving them their allergen, the people do have to remain in the office for up to 30 minutes. And that's just for safety precautions to make sure that they're not having any sort of problems breathing after receiving the injection. So like I said, this is someone who's committed to the idea of treating their allergies because there's a lot that goes into it. And of course, you need to observe the patient for reactions, documentation. Um, allergy shots is something that people will use, though, it's kind of a last line of defense. I don't think you'll see it quite as often as the drug therapy. So we've talked about allergies today. We will be covering these medications again in different chapters, but I think this is a good place where we start looking at medications. Prior to this, we really have been concentrating more on administration techniques, equipment used, medications, where did drug law come from, that sort of thing. From here on out, we're actually going to be headed in more towards actual medications. And so this is where we kind of shift our focus. So right now, you're going to do your homework for Unit 14, get ready for the exam for Units 11 through 14. And then when you're ready for 15, this is where we're going to make a shift into more of the actual drugs and how they work and when we use them, which is kind of the exciting part for me. I love giving these overviews and kind of giving you guys this information, but my bread and butter is more with the actual medications themselves. So any questions about the presentation, feel free to post a question in the forum or look in the forum for that question. Otherwise, I hope you guys are having a great week, and I'll be back for Unit 15.